Welcome to AETCM, the emergency medicine channel. Today, let us discuss about some of the important factors about hypoglycemia. Hypoglycemia means blood sugars are low and that low blood sugars are producing symptoms. Sometimes you can see blood sugars are low and patient is totally asymptomatic. Most of the time that is due to the lab error or your glucometer might have given a wrong value to you. But when it is symptomatic, when the patient is symptomatic, you need to act urgently. Sometimes blood sugar may be low, but patient is asymptomatic. Then either you have to reduce the dose of insulin, you have to avoid the dose of insulin, or you have to give some oral glucose to the patient to prevent symptomatic hypoglycemia. So this is a clinical syndrome characterized by low glucose level, symptomatic sympathetic nervous system stimulation. That is very important. Symptomatic, it has to be symptomatic. And sympathetic nervous stimulation like palpitation, sweating, tremors, all these things. And CNS dysfunction. Patient can have altered behavior, low GCS, all these things. So whenever a patient comes to emergency room with low GCS, instead of thinking big reasons, always rule out blood sugar. And if it is less than 60 milligram per deciliter, this is called as hypoglycemia. This is most commonly occurring due to drugs like sulfonylurea, like glipizide, glibenclamide, gliclazide, all these things, and insulin. If the patient is on insulin or sulfonylurea, that is the most common cause for hypoglycemia. One of the important things you have to understand is when the patient is on insulin, if the kidneys are normal, insulin will be excreted out through the kidney or removed through the kidney. But if the kidneys are abnormal, if the patient has developed renal failure, the requirement of insulin in a diabetic patient with nephropathy will slowly come down because of the reduced excretion through the kidneys. That type of patients can develop frequent hypoglycemia. Reactive hypoglycemia occurs when the patient had undergone gastrectomy and he is on insulin or not on insulin, whether the patient is on insulin or not on insulin. If the patient is having gastrectomy history, there will be, after taking food, there will be increased insulin secretion from the pancreas, but sudden emptying of the food from the gastric area, so stomach, that can produce hypoglycemic episode because of the increased secretion of the insulin from the pancreas, but food is not staying in the stomach. So that is not related to diabetes, it's a problem occurring after gastrectomy. Pseudo hypoglycemia means that is an error. That's why I already told that whenever sugars are very low in your glucometer or in your lab investigation, if the patient is absolutely normal, then you should rule out pseudo hypoglycemia. There are conditions like leukemia, polycythemia, and all can get pseudo hypoglycemia. Spontaneous hypoglycemia means patient is not on any insulin, not on any oral hypoglycemic agents like gliclazide, glibenclamide, all these things. If the patient develops hypoglycemia, there are multiple reasons for that. Patient may be on alcohol, malaria, sepsis, quinine, that's some antimalarial drugs, gatrifloxin, nowadays we are not using this drug, salicylate, and insulinoma. One of the most important cause for hypoglycemia, that is spontaneous hypoglycemia. If the patient is completely asymptomatic and you are getting a hypoglycemic patient in emergency room who is not a diabetic, not on insulin, not on oral hypoglycemic agents, you have to always suspect insulinoma. That's why whenever we are getting a hypoglycemia in a non-diabetic patients, always take a sample for serum insulin levels. That is very important, because if you want to make a diagnosis of insulinoma, the first investigation will be serum insulin, and that has to be high. When there is a hypoglycemic episode. Now, hypoglycemia and counter-regulatory hormone. Whenever there is hypoglycemia occurring in our body, there are some hormones. That is, one is glucagon that is secreted from the pancreas itself. Catecholamines like adrenaline, noradrenaline, cortisol, growth hormone. All these things will counter-regulate. That means if the insulin is increased, hypoglycemia occurs. Then counter-regulatory hormones will try to compensate that. They will prevent the hyperglycemia. Sorry, they induce hyperglycemia and prevent hypoglycemia. So this is a normal mechanism occur in our body. So this glucagon can be utilized as an treatment regime when there is refractory hypoglycemia or severe hypoglycemia or dextrose is not available. Now, the action of insulin is just opposite of the glucagon. So that is very important. So it is just opposite of insulin. So whatever actions of glucagon, that is just opposite insulin. So insulin reduces the sugar, but glucagon increases the sugar. That is a major difference. So this can be utilized as a treatment regime for hypoglycemia. Now, if you see the symptoms of hypoglycemia, there are two important symptoms. One is neuroglycopenic symptoms, and third one is adrenergic symptoms. Neurogenic symptoms are sweating, palpitation, tachycardia, tremors, anxiety. So, neuroglycopenic symptoms is reduced sugar in the brain. They are like dizziness, headache, clouding of vision, confusion, behavior abnormality, convulsions. So they are called as neuroglycopenic symptoms. Next one is adrenergic symptoms. That is due to they are mainly seen in rapid onset of hypoglycemia, and neuroglycopenic symptoms are seen in progressive hypoglycemia. So adrenergic symptoms or neurogenic symptoms, they are an important clue for hypoglycemia. But patients on beta blocker, these symptoms can be absent. They suddenly develop coma and convulsion. But anybody who is not on beta blocker, if he develops hypoglycemia, all the symptoms will be there. Adrenergic symptoms will be there. If they are on beta blockers, these symptoms may not be there. These acute symptoms may not be there. Suddenly, without all these symptoms, patient will go to convulsion on or coma. So that is a problem in a patient. That's a real problem in a patient who is on beta blocker, who is on insulin or sulfonylureas. This is called as hypoglycemia unawareness. So the patient is on some drugs like insulin or sulfonylurea. He is on beta blocker also because of some other compelling indications like myocardial infarction, previous myocardial infarction. If he develops hypoglycemia, he will not have the adrenergic symptoms like palpitation, sweating, all these things. Suddenly, patient will go to coma and convulsion. So one of the most important problem in beta blocker who is who is uh, uh, who is already having diabetes. So that is this hypoglycemia unawareness. So beta blockers are indicated only in patients who is having diabetes with coronary artery diseases. Otherwise, unnecessary starting beta blockers in diabetic patients. They are good drugs. Beta blockers are very good drugs. They are good for heart. They are good to control the BP. But in a diabetic patients, they are not good because of this problem. But this is not a severe problem. We can advise the patient that other symptoms may be there, like clouding of vision, weakness, all these things will be there. Patient can even test the blood sugars. But we try to avoid beta blockers in diabetic patients. Compelling indication for beta blockers in diabetes is coronary artery disease or acute myocardial infarction only. Nocturnal hypoglycemia can be asymptomatic in many patients, but patient can have night sweats, poor quality of sleep, morning headache, hangover, chronic fatigue, vivid dreams, nightmares, restlessness, muscle twitching or convulsion. This nocturnal hypoglycemia is a very, very important problem, because when you are giving, for example, you are giving 25 units in the night, around 8 o'clock we are giving 25 units, patient takes his dinner, then night around 2 a.m. he develops hypoglycemia. Maybe blood sugar is less than 50. Then these counter-regulatory hormones start acting, like glucagon, growth hormone. Then sugar will surge in the morning, 300 or 400 will be morning blood sugar. So if you don't understand this problem, you may increase the dose of insulin in the night time to 35, thinking that more insulin is required. So again, the problem will occur in the night. These sugars will be further high, 350, 450, like that. So what happens is, whenever blood sugars are very high in the morning, you have to always check a 2 a.m. blood sugar and rule out hypoglycemic episode. The Somagi phenomenon we have discussed in the previous classes. Now there is a condition called as insulinoma. Spontaneous hypoglycemia mostly due to insulinoma. One of the triad explained in that condition, insulinoma, is Whipple's triad. Symptoms of hypoglycemia. So patient will have symptoms of hypoglycemia. Blood sugar values are very low. Some books may give it less than 50. Some books may give it as less than 60. So that's not a big problem. So if the symptoms are there, less than 50 or less than 60, whatever it is, okay. Because glucometer always gives some difference in value from lab investigation. And relief of symptom following ingestion of glucose. This is called as Whipple's triad. This is applicable for any type of hypoglycemia, but this Whipple's triad is basically described in insulinoma. All these things occurring without patient on OHA or insulin, then that is a sign of possible insulinoma. If the patient does not have sepsis, infection, malaria, not on any drugs which can produce hypoglycemia, then Whipple's triad may indicate an insulinoma. Now, blood sugar values can be taken with glucometer in emergency room, but remember, there is always 15% error in glucometer values comparing with venous values because of the error in techniques. So you can see here the technique is clearly mentioned. I am not going to the technique how to take, but if you squeeze too much squeezing, too much adding spirit to the finger, all these things will create problem in a glucometer value. So you always think about 15% error. 15% can be high or 15% can be low. Okay, so that is a normal acceptable error. Now serum insulin should be taken in a patient who is having hypoglycemic episode, because hypoglycemia as such we always try to treat with dextrose or 5% dextrose or 25% dextrose or 50% dextrose, whatever it is. We try to treat with dextrose. But if there is no diabetes, patient is not on insulin, patient is not on OHA, remember this can be insulinoma. There is a chance of insulinoma present. Whipple's triad we have already seen. So always try to take two important investigations in a spontaneous hypoglycemia. One is serum plasma insulin level. That is very important. Other one is C-peptide. C-peptide is also should be taken. All insulinoma patients have higher values of C-peptide, and all normal subjects who were hypoglycemia have lower values. So a C-peptide, suppose you are giving insulin and patient develops hypoglycemia, C-peptide will be normal. C-peptide is a precursor of human insulin. So C-peptide will be higher, insulin will be higher in both C-peptide and insulin will be higher in insulinoma. So that is very important. Sometimes if we are missing the diagnosis in emergency room, then prolonged fasting is required in that patient to take the insulin level. So that is also can be tried. We are not going to go to the details of this prolonged fasting testing, but it is given here. You can read about that. Okay. Now, management of hypoglycemia is very, very important in emergency room. We always try to give oral glucose whenever patient is having hypoglycemia at home or when we bring the patient to emergency room. We can give oral glucose or we can advise the patient to take oral glucose. Whether it is hypoglycemia or hyperglycemia, symptoms for patient will be always similar. Patient will have dizziness, vertigo, or reduced consciousness. All these things, it is both present in hyperglycemia and hypoglycemia. So when in doubt, always give blood like oral glucose, because hypoglycemias are more dangerous than hyperglycemia. So if the patient is unconscious in a diabetic patient who is unconscious and you don't have any testing machines with you, like the glucometer is not available, give some oral glucose immediately. If the patient improves, then that is hypoglycemia. But that is for bystander. But in hospital, we always check the blood sugar with the glucometer, and we start IV dextrose. So dextrose can be started 50 ml, 50% dextrose, and that can be started. And if the patient is having hypoglycemia due to sulfonylureas, most of the sulfonylureas are long-acting drugs. So you have to give continuous infusion of dextrose. So that has to be done. And if the patient is having insulin-induced hypoglycemia, especially long-acting insulin, with elevated creatinine, you should know that the action of insulin will be further prolonged. In that condition, also you have to give continuous dextrose infusion to prevent further episodes. And even you can try glucagon. If the patient is having recurrent hypoglycemia, glucagon 1 mg can be given IV, intramuscular, or subcutaneous insulin. So that is very important. So this is the chart which explains you how to treat a patient who is having hypoglycemia. Same thing, whatever we have discussed, it is given as a chart, that's all. And we have to always check the blood sugar every 30 minutes till the blood sugar more than 100, because many a times patients may further go to hypoglycemia after the initial correction. So we have to continuously monitor and continuously give it as infusion. Now, there are some differentiating features between hypoglycemia and hyperglycemia, but in practically, when we are treating in emergency room patients, practically it is very difficult to make out these type of things. But hyperglycemic coma, most of the time, if it is DKA, patient will have acidotic breath. Where hypoglycemic coma, patient will be completely having sweating, and their BP may be low, all these things. Even in hyperglycemic coma also sometimes BP can be low, because the HHS patient loses large amount of water. So these things may not be very useful in emergency room. In emergency room, you always depend on the glucometer. Glucose value less than 50 or less than 60 is very, very important. Other things, theoretically, we can see all these things. If you can understand, it is well and good. But if you are not able to understand, glucometer is not there, start him on glucose. Because even in hyperglycemic coma, whether it is DK or HSSC, even if you give additional one small vial of dextrose, nothing will happen to the patient. But it is hypoglycemic coma, if you don't treat it properly, patient can have permanent damage to brain. So always better to give the glucose if you are in doubt. So we have discussed about hypoglycemia in detail, but further investigation on insulinoma cannot be done in emergency room. So we have just investigated insulinoma in emergency room by doing an insulin level or C-peptide. That's all we can do. But other investigations, like a patient who is having hypoglycemia can have like skipping of meal, or renal failure, or infection, malaria, sepsis. All these investigations has to be done, because suddenly if the patient developing hypoglycemia, it can be due to our usage of insulin or oral hypoglycemic agents, but sometimes it can be due to dangerous conditions like infections or malaria. So we have to be very careful. And spontaneous hypoglycemia, you have to take two important investigation. One is serum insulin level and C-peptide. That has to be done. Otherwise, patient has to have a prolonged fasting, and next day we have to take additional sample. So to avoid that, immediately take insulin levels in this condition. Okay.